camera. Okay, welcome everyone. Bienvenidos, bienvenidas. So today we have our second invited speaker for the Drexel Climate Change and Urban Health Research Center. So reminder, this is an NIH-funded center that works to understand the impacts of climate change on urban health and health equity with a focus on cities in the Americas. So this is our invited speaker series. We have 4 throughout the year. The 2 more are coming at some point in the rest of the winter and the spring. Can't remember the details now. But today we have the honor of welcoming Dr. Ricardo Castillo. Dr. Castillo is an assistant professor of epidemiology at the Perelman School of Medicine at the University of Pennsylvania, so somewhere over there. And he's also the scientific director of the Zoonotic Diseases Research Center, which is a collaborative research consortium between multiple US-based and international institutions that employs over 30 full-time staff. He systematically applies the One Health approach to study tropical infectious diseases in Latin America. And Dr. Castillo has focused his research on the epidemiology of zoonotic diseases in urban areas, which are the fastest growing ecosystems in the world. We usually don't think of cities as ecosystems. I'm very excited to hear about that. He's the PI of 3 NIH-funded projects that focus on the socio-spatial dynamics of urban infectious diseases, the optimization of mass vaccination campaigns to control epidemics, and the training of Peruvian scientists. He's also the co-PI of a Mellon Foundation project where he studies the intersection of social inequalities, access to health services, and the emergence of infectious diseases, which is what he's going to be presenting about today. He has a degree, he has a veterinary medicine degree from the Universidad Nacional de San Marcos. I was going to say Cayetano Heredia, but no. And then an MSPH and PhD from Johns Hopkins, where we met 10 years ago, or 11 years, 12 years ago. And some time ago. We used to play soccer and all of that. And other things. Okay, so again, thank you, Ricardo, for being here. He will present for around 40 to 45 minutes, more or less, and then we'll open it up for questions here in the room and through Zoom. Please use the Q&A questions so we can make things easier. And one more thing, if you need a live interpretation to either Spanish or Portuguese, please use the little world button in Zoom and choose your language of preference. Okay, thank you. Thank you, Ricardo.
Thank you. Thank you so much for that nice introduction. Today I'm going to talk about a new study. I'm not going to talk about my usual subject, which is rabies, but something that we just started working on a year ago. Susana said my work is focused or is based in this area in southern Peru, in Arequipa, where we have this consortium between Penn and Cayetano Heredia, Peruvian University there. It's the Zoonotic Disease Research Center, so we study zoonosis, and these are the ones that we study there. With a heavy focus on rabies. And I'm going to use this presentation to walk you through the last years of my research and how that led me to the project that we conducted last year, as someone said, funded by the Mellon Foundation. So rabies, I started working on rabies about 10 years ago, and specifically on dog rabies. Most of the human cases of rabies are mediated by dog bites. And we have worked on surveillance, control, many things, but about dog bites, people need to wash the wound, they need to identify the dog, and they have to go to the medical facility. The last piece is very important because through that is that we provide vaccination to people, and we also estimate the burden of disease. So I was working on that. We conducted this quantitative, qualitative study, going door to door to more than 4,000 houses, trying to find out who was bitten by dogs. And we conducted also focus groups to see what the areas they experienced accessing healthcare. And we did that in 21 urban communities and also 21 pueblos jóvenes, shantytowns, in the peri-urban areas of Arequipa. In this city, we have active rabies transmission in dogs, one of the few Latin American cities where rabies is very prevalent. And then we found these are some of our communities in urban and peri-urban areas. The peri-urban areas are in green there. And we first started with who got bitten. And in Arequipa, 5% of adults every year are bitten by dogs in the urban areas. Established communities, a little well off compared to peri-urban communities. This is almost 3 times higher, the dog bite rate in the peri-urban communities. This is the highest reported ever in the world. I talked with more senior rabies researchers. They asked me, what is this health that you found? You know, and I'm like, oh, it's in southern Peru, and we're trying to find out what people have to do to access healthcare. And this is, some of you are sure that, or maybe most of you are familiar with this. Walking on those peri-urban communities is not easy. And now we also asked who sought medical care after the dog bite. 40% of people in the urban communities sought medical care, but only 21% in the peri-urban communities. And here you can see the distribution of medical facilities, because we also map where the medical facilities are. All of them or most of them are located. These are just some of our study areas, but in some other areas there were small health posts in some of these peri-urban communities. Of course, there is a spatial inequality, how we distribute resources for these people. And then we conducted these focus groups trying to find beliefs, attitudes, practices regarding dog bites and treatment. We can talk about, for example, I'm not going to discuss that now for the sake of time, but we can talk about the hair of the dog that bit you, that saying that we use here for hangover. That came from the Middle Ages, and it was a treatment for rabies. And we found that in some of these focus groups. But people in general, they reported, the usual suspects: limited service time in health posts, logistic distance time, and money, but also mistreatment and low quality of service and discrimination, which is something that, unfortunately, very sadly, we saw when we talked with some of the physicians in some of these health centers, and they referred to these people from the peri-urban communities as second-class citizens that should just accept whatever treatment is offered to them. And this is one of the participants, a woman in the peri-urban area, saying that they mistreat us there, they don't attend to us. The doctors say, oh, there's no pills here. This is in the small health post that they have in their communities, so they're sent down to the health centers in the more established communities. In the health centers, the doctors say, why are you coming here? You have your own health post, go back there. So people stop believing in these providers, and these are migrants. And then, of course, it was so clear in our focus groups that the population was so different. I was living in Arequipa at that time. I very rarely visited these peri-urban communities until I started doing my research. The populations were completely different. And they started telling me their stories about why they were coming to Arequipa. There were so many seasonal jobs that I didn't know about. Even mining sometimes is seasonal in Arequipa because of the rains. People come and they come with their animals, right? They come with their animals. We conducted some genomics on the rabies virus samples that we have from dogs. And yeah, someone came with their dogs. That's what you do, especially for internal migration. And it was introduced from Puno to Arequipa. Puno is the only area in Peru where we never controlled rabies. So it was always prevalent there. It was active transmission, and it entered Arequipa. So I got interested in migration. Okay, something is happening here. I was just focusing on Arequipa. And in 2020, I joined the Lancet Countdown Health and Climate Change in South America. And this is a huge group of researchers. And our task was to conduct this critical analysis of the national plans for adaptation for climate change in the 12 sovereign countries in Latin America. Interestingly, we found almost nothing about migration and how to prepare for the impact of climate change, the impact that climate change is going to have on migration. I was working on this manuscript, on this research, when this outbreak that we were, or at that point it was an epidemic of dog rabies, expanded from the city of Arequipa, now to a new city called El Pedregal in Majes. It's 2.5 hours driving from Arequipa. There were multiple cases there. And it is so close to Arequipa, and the cases occurred within the span of 1 year that it was attributed to Arequipa. It was like, oh, someone brought the dog here, and that started the outbreak. Again, we did some genomics on those samples, and we found two different phylogenetic groups. Some of the cases came from Arequipa, but also some of the cases came from Puno. It was two different outbreaks happening in the same area. Again, related to migration. Pedregal became a very interesting place for me to study zoonotic diseases because migration is huge, and I'm going to talk more about that. But we were not new in Pedregal. In our center, as I mentioned, we also studied Chagas disease. So there was this postdoc, Raquel Gonzalez, who is now here at Penn. At that time, she was living in Arequipa. She was conducting focus groups there, trying to understand how that these Chagas disease vectors, like insects, the kissing bugs, the transmit Chagas, came to this new city. Because that is rare. It's very difficult for these vectors to urbanize, to adapt to these new ecosystems. So in this study, this was a small study that we conducted there. We found all factors, right? And what is attracting people here to this area, right? Economic opportunities, year-round employment, access to land, which was important for a lot of migrants from rural areas, better education, to reunite with families, right? Many of them said that I wanted to be closer to my family and expand in economies. But I was talking with an anthropologist. He's American, but his parents are Peruvian, and he studies the Andean cosmovision. He was like, migrating and living in a community in the Andes is so rare. It's something that people are so connected to their communities, to their animals, but to their land. So something that then we didn't explore at that time is like, what are the push factors? Why are they living in these areas where they have these very strong attachments? So we started this bigger study in El Pedregal. In El Pedregal, I think it's fascinating because it was originally an arid desert plain. There was nothing. It was unsuitable for agriculture or human settlement. And the region's dry climate and scarce water resources made the area infertile and inhospitable. But El Pedregal is located close to the coast with great access to roads, and also close to the Andes outskirts, where we have a lot of a huge water supply in the Andean glaciers. These Andean glaciers, they usually also provide water to some rivers. So in the 70s, the government started this project, this irrigation project. They wanted to make that area fertile. And in the 80s, the irrigation system enabled the cultivation of some crops, alfalfa, grapes, and maize, and that attracted some rural migrants and new settlers in this area. They were looking for opportunities, and they found water and arable land available in this area. And in the 90s and in the 20s, there was an explosion. There was also an industrialization of farming in El Pedregal. There was an agricultural boom, and they began raising and packing and exporting a lot of products, avocados, asparagus, grapes, onions, and other products to dozens of countries. It grew so fast and so much that now there is a project to build an airport half an hour from this area because so many people want to see their business. You know, there is a lot of economic activity in this area. You can see how the landscape changed and people transformed the landscape with these waves of migration during these couple of decades. So in 2024, we started a study in El Pedregal to understand the experiences of these migrant population. We conducted structured surveys, focus groups, in-depth interviews with community leaders and community members. And we uncovered diverse stories of migration linked to health and to climate change. We started planning everything with the local public health officials. That is our team, and the person who is right in the middle is one of the physicians in the health center of El Pedregal. There's only one health center in this area, and they have 80,000 people now. That's grown from nothing in this area. It was a completely deserted. Now they have 80,000 people. And it's interesting because they're clustered, but they're completely surrounded by agricultural land. So it's considered urban, technically rural. Their jobs are not traditionally urban jobs. So we started the field work with planning with local authorities, a pre-screening phase to try to find migrants from some specific areas we were interested in, especially from Puno and Cusco. And with that pre-screening, we were trying to find these clusters of people coming from Espinares in Cusco or from Melgar, some specific towns in those areas. And then we conducted 5 focus groups, 37 in-depth interviews, and we planned 1,000 door-to-door surveys. We're going to talk about that. That was the plan. And these surveys, for these surveys, we had this instrument that had 2 components, one for household level data and the other for individual level data. At the household level data, we wanted the general home information, tenancy of animals, land tenure, difficulties after migration, difficulties in access, in health access, food insecurity. And at the individual level, for socio-demographic information, but also migration history, pull and push factors, forced displacement. We were interested in that. It could be political, or it could be more related to natural disasters. Perceptions of climate change, changing dietary and behavioral patterns, physical activity and inactivity. We wanted to compare some of these trends to the Peru migrant study from Jaime Miranda, a large study that was conducted in Lima. And I'm going to present the results divided in 4 categories. Jobs and land corruption, food security, access to public services, and entities neglected tropical diseases. Maybe you notice that the 5 zoonotic diseases that I mentioned at the beginning, if you're not familiar with those zoonotic diseases are considered neglected tropical diseases, and I will talk a little more about what that means. So jobs and land corruption. So migrants with they had different times since migration. Our participants. We wanted to understand their pull and push factors, and we wanted to transport them to that specific moment in which they were leaving their towns, or those few months when they just arrived in the Pedregal and they were adapting to this new area. So Joanna Brown, a Peruvian psychologist there, is guiding this meeting, and she had this wonderful idea of making them draw their towns. All of them had to draw and remember their towns, and they became emotional. It was a very interesting exercise, and we needed that because by connecting them emotionally to that moment of migration, we can trigger better memories. We can get a better response about what happened in those times. And most of our participants came from the highlands, mainly from Puno, and they described their homes as these beautiful towns where they live with their families, working their own land, they're raising their own animals. But also in these areas, their memories were mostly good, but they lacked education, work opportunities, and other factors push many to seek a better future elsewhere, right? Better opportunities. So El Pedregal is located in the Majes district, and when you arrive to Pedregal, this is the first thing that you see. Majes, land of opportunities. So El Pedregal represented hope for them. And people say, in El Pedregal, it's a place where anyone could work, and you don't need to be a professional. So there are many jobs, as we found in the Chagas study at the beginning, but we found a lot of issues also with jobs. People form crews of workers called cuadrillas, and they offer their services at pickup points where they are transported to the fields every day. Most of the time there are jobs, but the jobs are 12 hours in the field. I've never experienced more intense sun in my life than here. The radiation is extreme. There are some people studying here, for example, kidney diseases, kidney failures, because of that level of dehydration. I walk there for 2-3 hours sometimes, the headaches that I get, I'm not working there. So I cannot imagine the conditions that they have to experience there. But also they offer this, they offer their services there, but also sometimes they're not indoors outside of the processing plants. Now, as I mentioned, this area has industrialized and there are multiple processing plants. They usually prefer women for this work. The men, they're stronger, they go to the field. And a lot of women reported sexual harassment and even sexual abuse within these plants. They need the jobs, people take advantage of that. And this was very common in multiple focus groups. Talking about the push factors, what is pushing people away from their areas? People reported natural disasters. The older people who migrated in the 80s and in the 90s, they reported also terrorism. But one of the participants said, we had suffered a flooding, almost half of the land has disappeared, the houses, the schools, everything, we have been isolated. 72% of people here reported extreme weather events before they migrated. And so a lot of them lost their lands, or it was very difficult to continue living in their communities. And help came in various forms from the government. Some of them received land in Epidemiology. Some of them had to navigate, these very tedious bureaucracies trying to claim their rights as victims. In some cases, they obtained something, but some of them never received anything, and they just went to Pedregal to look for opportunities. The problem is that both formal and informal corruption emerged as a significant challenge. Land corruption emerged as a significant challenge in these areas. One of our participants said, but since I did not know them well, they were high-flying people who were traffickers of land, and they began to reap 1,000 soles for the subscription. So he shared his experience receiving land designated for victims, only to have it resolved by those who were supposed to assist with the management of this piece of land. Another person said that he does what he wants, he gets paid, he wants to become the owner, he keeps people out, and it's talking about an illegal community leader. Some people just proclaim that they are, sometimes even the mayor, they call it, I was there, and they were like, oh, I'm the mayor, and then I asked people, like, there are no elections here, nobody voted for him, but he's using, his entourage people and going and telling him his position in the community. They took charge of the land that is supposed to be given to the victims, and they start negotiating that land. We will see also that job opportunities and working is also associated with food security. Single mothers face great obstacles in this area to manage child care while also trying to secure food for their families. Families adapt to this food insecurity by reducing the portions. We have a nutritional epidemiologist in the team. He's amazing. He's Peruvian, and now he just started a postdoc in Michigan analyzing this data, how people are reducing the portion of their meals. Some people report having only 1 or 2 meals per day, in many cases because of lack of resources, and many times because they cannot stop working in their land. 70% of people are temporary workers or informal, or they have informal jobs. So these offer the little security and no benefits. And as I mentioned, job opportunities and food security go hand in hand here. One of the participants said, at my age, there is no work. They don't give you work for those over 45 years old. So we have to create our own work. And they said, you can go to the farm, you can bring back anything, right? Or as they say, payapeo. We learned about payapear, this verb that they use for after the official harvest, the technified harvest occurs in the field. They go and they try to find whatever scraps or whatever leftovers are in the field to get some food for their pantries. And only a few families reported supplementing their diet with meat from their own small livestock, and even fewer families have large livestock in this area. Many mothers, especially mothers, they in the focus group they said, sometimes I skip 1 or 2 meals a day so I can provide meals for my children. Another aspect of what we found is access to public services. We spend a lot of time studying access to healthcare, but I'm going to focus here on more environmental problems. One of them is waste. This dam is located maybe 200 meters from the houses. There is one official slaughterhouse in the area and multiple unofficial illegal slaughterhouses. And they, not only the illegal one, but sometimes even the legal one, they dump carcasses just very close to the community because it's cheaper. This is linked to more feral dogs and more stray dogs in the area that might be linked to rabies, but also to many other problems. So providing appropriate waste management services for this huge population is a challenge for this district. But water, one of our field workers in the team is from El Pedregal. So he started telling us this story when we were planning. He said, the joke is that when you move to Pedregal, you have diarrhea for 3 months. That is the joke that they have in El Pedregal. Every person who just comes, they tease that person for the month. This is one of the many reservoirs of water that they have, really open. From those reservoirs, they have these water channels where they distribute water to multiple places, and they have these water trucks. They take water and they just go straight to the houses to provide that water. And it says, I don't know if you can read, but it says potable water. Right? That is supposed to be drinkable water. In many places, also many of these smaller communities within Pedregal, they store the water in these containers. Some of the people in the focus group said, some days the water looks like Coca-Cola. And when that happens, these people are so resilient. They go and they collect these cactus leaves. They're not actually leaves, it's pencas, right? The pencas of the cactuses, the green portion of the cactuses, and they get this kind of syrup, from this gum from inside. They mix that with this very dark water. That is flocculation, right? So you get all these particles, or many of these particles, to sediment. And that way they clarify the water, they clear the water some, and then they boil the water. Still, it's not the best water you can get, but that's what they do in these areas. From the surveys, they experience so many difficulties accessing these basic services. Just with the first one, you can see 81% of them reported at least some difficulty accessing potable water, and more than 60% report great difficulty accessing potable water. And neglected tropical disease. This is something that I was, of course, very interested in because this is what I've been doing all my life. The neglected tropical diseases are infectious diseases that do not receive enough political or financial attention compared to the burden of disease that they cause. And usually they are located in the tropics. And another characteristic is that they affect what we call the poorest of the poor. So many times we don't say neglected diseases, it's just neglected populations, right? These are neglected populations, and that's where they have this burden of disease. So we were interested, on top of understanding migration and all this, to also measure disease, measure the burden of NTDs in these communities. So in addition of the door-to-door surveys and the qualitative studies, we run a battery of diagnostic tests on Fasciola hepatica, a parasite that lives in the liver that causes from mild to severe anemia in children and adults. Cysticercosis is what is associated with a human tapeworm. Sometimes it goes to your brain, you get a cyst there that grows, and it causes seizures, and sometimes even death. And cystic echinococcosis is a parasite that is mediated by dogs. It's a dog zoonosis. The usual life cycle is dogs and sheep, and it lives there. That tapeworm, it lives in the dogs, the eggs contaminate sheep, and in the sheep it produces a cyst. Then the dog eats the innards, gets contaminated. But sometimes we get those eggs from the feces of dogs. People in these rural communities, especially children, they are playing with the dog, they lick whatever, and they contaminate children, and they develop these cysts, usually in their livers and in their lungs. They're the size of a fist. Many times they do not respond to treatment, to antihelmintics, so they need surgery. A few times those cysts can reach the brain in children, they need surgery. Surgery is dangerous because it just breaks a little of that cyst, you contaminate the area, and you can produce many more cysts. So it's called white cancer. Sometimes they call white cancer. So I was interested in those three diseases. And that's why I talk about the pre-screening phase. We wanted to find people who were coming from hyper-endemic areas for those diseases. People in Puno and Cusco, there are some towns that are hyper-endemic. We're talking about 5% for fasciola, 10% for echinococcosis, 1 to 2% for cysticercosis. So the planned study population was 1,000 males and females from 6 years old who lived in these endemic towns. If you look at the literature, nobody runs all these many different tests to look for those diseases. Yes, sometimes, usually one, sometimes two. We wanted to do imaging, X-rays and blood samples, stool samples, urine samples, everything to find these cases. And now, poverty traps, that's in the title. NTDs. So, what is a poverty trap? So, this is a very simple model to explain a poverty trap, just based on income. Here, in the x-axis, we have the level of income at time t. You can think of that like right now. And then on the y-axis, we have the level of income tomorrow, right? Or next month or next year. It's time plus 1 units. Usually, many of these big push programs assume that that association is this straight line, right? The more income you have today, the more income you have tomorrow, and that's a straight line, a straight correlation. But that is not how it behaves. Usually, it has this S-shaped curve. And what happens is that it's really, really difficult to cross that threshold, that inflection point. And before that inflection point, you don't cover your basic requirements, and you continue being poor. And that is the poverty trap. Once you reach high income or middle income, usually you reach this steady state. And even if you fall down a little, you can live again, and it's more stable at that point. This was postulated decades ago. Then someone used this to explain how nutrition, for example, can be a poverty trap, right? You don't reach, your basic nutritional requirements, and you stay poor. So the group from Matthew Bones at Harvard has been working on this model of NTDs as a poverty trap. This is a basic infectious disease model, right? We have, especially for NTDs, there is no immunity, no vaccines. So everyone who is born in these communities is susceptible for these diseases. And through the process of transmission, some of them will become infectious. Some of them might die at a higher rate because of the disease, but some of them will recover. And then when they recover, again, they are not immune. They are susceptible again. Very basic infectious transmission model. But now we have economics, we have capital. We have capital, and capital can influence transmission, can reduce transmission, for example, and can increase recovery. Capital through production increase income, and income through investment increase capital. But for those who are infected, or in this case, the disease, reduce production, and the disease also reduce investment. So this is a poverty trap proposed for neglected populations. And this is an adaptation from Ongala. So this is coupling an infectious disease model and an economic model. So migration has been proposed, and it has been shown actually that it's a pathway out of poverty traps, right? Especially when we think of international migration, many poor people whose labor is their only asset, when they go to another country that make more resources, they find opportunities to escape poverty. The poorest of the poor usually stay in their own countries because it's difficult to afford those kind of trips. And then when they migrate, they migrate internally. And through these mechanisms, sometimes we see the healthy migrant effect, which was also shown in this Peru migrant study for chronic diseases. Our hypothesized effect of migration on NTDs in this population, of course, is that they are moving to an area where there is no transmission. It's an area that is not endemic for these diseases, so there is no transmission. Also, if people have more capital, recovery is faster. And also, they reduce infectivity, so these negative effects on the investment in production are reduced or completely stopped. So we're like, great, let's see our hypothesis in this community. We wanted to measure disease, access to healthcare. If this disease, you can measure if they are changing state and if they are viable, if they are recovering. We wanted to see all those transitions. We were super excited, as you can see in this picture. This is one of our teams going to recruiting people, start collecting samples, taking them to the clinics to look to do the X-rays and all the other tests. We completed 349 surveys in these communities, and we conducted 234 complete diagnostic tests. So we tested 274 people there. How many we found? 0 positive to Fasciola, 0 positive to Taenia solium, 0 positive to Echinococcus granulosus. So all these people were recruited for hyperendemic areas. What is the probability of finding 0 cases of cystic echinococcosis in this community? The average reported prevalence in rural Puno and Cusco is 9%, just for one of these diseases. You sample one person, and of course, the chances that that person is negative is 0.91. You sample 274, the chances that all of them are negative is that number, right? The probability is it's extremely, extremely low. So the healthy migrant effect might explain this. Which mechanisms? There are many proposed mechanisms for how the healthy migrant effect shows better health in migrants, but we believe that these might be the 3 ones. Self-selection before migration, based on what people said, and this is something that I've just shown, that people said the first 2-3 months when you arrive here, a lot of people go back. We can hear usually waves from one community, and a lot of people just go back. Who is going back? Who are these people who cannot work 10, 12 hours under the sun, you know? As I mentioned, one of these parasites affect your lung, your lung capacity. The other causes anemia. The other causes seizure. How can you work as part of other people? So it's not only selection before migration, but especially during settlement. Survival effect, many people said you have to be very strong to survive in El Pedregal. And when they say survive, most likely they're talking about enduring the hardship of adapting, but maybe it's also that is explaining that. But it is important, I think, especially when we have people trying to show that migration might influence or might bring more people infected, and at least most of the healthy migrant effect literature is associated with non-infectious diseases. In fact, there is one report from the Lancet Commission on Migration saying that for some diseases, migrants have a higher risk for infectious diseases. This is not what we found, even though this is internal migration, completely different what we found. But what is the effect on the rural communities of origin? Because we're talking about individual level, everything is individual level. But now I'm thinking of what's happening in the communities that we didn't visit and where these migrants are coming from. So this is a different model. We have an economic model now that starts with human capital. You have good human capital, you have good productivity, that produces income. Income gives you more access to education and to healthcare services, and that increases your human capital at the individual level. That income also increases community assets through donations, taxes, expenditure, investments. Those community assets now can directly be invested in better education, better health services in the community, or increase social and cultural capital in those communities, which in turn increase human capital. But this is my framework for a community poverty trap, not an individual, but a community that now is keep track when we think of NTDs and migration. And again, we start with human capital. Now that person is sick. Human capital is this integration of skills, knowledge, health, education, but now that person is sick. So low levels of human capital leads to low productivity, which produces low income. And you have all these negative feedback in these communities. And on the community level, we have low community assets, low social and cultural capital, which just keeps this community in this poverty trap. So these are some conclusions. So these large-scale infrastructure projects, which are growing a lot in Peru. Peru in the last 20 years ago, Peru was not in the list of exporters of vegetables and agricultural products. Now it's a top 10. All these large-scale infrastructures are growing, and of course that changes the land use in the areas, and that can have ripple effects on migration, settlement patterns, and health vulnerabilities. What we found also is that migrants, often from impoverished backgrounds, bear the brunt of these challenges, such as lack of clean water and exposure to vector-borne and zoonotic diseases. And climate change, in this case, manifested through extreme weather events, that's what they reported, is a significant driver of rural to rural and rural to urban migration in southern Peru. And despite its agricultural success, because when you go there, people just talk about how much money they are making. When you go to the city of Arequipa, a lot of investors are in the city of Arequipa, not in El Pedregal, and they talk about their investments in El Pedregal. They don't live there. They just invest money. They have cheap labor. Despite this success, El Pedregal continues to grapple with significant challenges. One of them, maybe the most important right now, is that those glaciers, those Andean glaciers, because of climate change, are reducing in size. The largest tropical glacier is in Peru, is in Cusco, and it has reduced 25% of its volume in the last 3 decades. So at some point, that area might be again completely arid and deserted. And the healthy migrant effect commonly reported for international migration for chronic diseases among rural to urban migrants appears to extend also to NTDs, potentially creating new poverty traps at the community level in rural towns of origin. I want to say thank you to my wonderful team. This is the people who collect the data, analyze the data that I showed, and thank you to our funders. The rabies data come from NIH, but the migrant study in the Pedregal was funded by the Mellon Foundation. And thank you to collaborators at Penn, the Ministry of Health. They have been great with this Mellon project, and regulatory institutions, especially Valerie Pasoldan, who has been leading the qualitative work in the Pedregal. Thank you.
Ricardo, so now we'll open it up for questions. If you have any question online, please type it on the Q&A section, and we'll ask it out loud. Meanwhile, let's start with the room here. Anyone?
Go ahead.
The moderator, Josiah.
Thank you so much. This is fascinating. So you're talking about the healthy worker effect and then the effect that has on the communities of origin. I'm wondering how differences in age affect that too. So more migrants are not only healthier, but perhaps younger.
Yeah.
And what's the impact on the communities of origin?
Yeah. So definitely we were thinking of all the different mechanisms reported for the healthy migrant effect, and the age distribution of the migrants compared to the people of origin is one of the usually reported mechanisms. But in this case, most of these diseases affect very young children. Sometimes school children for fasciola hepatica, you can find 20% of them infected with this parasite that lives in the liver. So that's why we didn't mention that as one of the potential mechanisms. Yeah, chronic diseases usually are more associated with age, but in this case, the infectious, the pressure of infection in these populations start at very early age.
If I could add follow up to that, with the other social demographic factor, gender. Is there any imbalance in the gender distribution of migrants? Because I remember from reading about internal migration in Mexico to the manufacturing in the north, it used to be men migrating and then it switched to be women migrating, and that generated a lot of pressure that you mentioned in that region. Is there any?
Something that we found, because we don't have a whole census to understand that very well. The data, our data shows just a very balanced distribution between gender, sex, but it was interesting that a lot of women said, we came from Puno, because in Puno, when you work the land, they pay you less if you're a woman. In Puno, but here in Pedregal, they pay you the same. So it's like if they work the land, that's good for them, but when they work in the processing plants, even a lot of them reported sexual harassment and even sexual abuse.
Yeah, thank you, Ricardo. I just wanted to comment. It's so nice to see sort of this ecological approach to understanding, migration and how it's impacting many, many things kind of at the same time. So this kind of ecosystem approach is really nice to see that, and integrating the sort of a One Health approach, which we don't do very much in public health, really. And it's great to see that as a veterinarian, you're doing this, right? Which is anthropological too, right?
Oh, yeah.
So I was wondering, has it been difficult to get this kind of work funded, because it is so interdisciplinary and it's not, how has that been in terms of?
We stopped recording. Originally, we were going to study just race and access to healthcare in Arequipa. The Mellon Foundation, the original proposal was just to study race and ethnicity, the distribution of race and ethnicity and their life experiences with discrimination and access to healthcare in Arequipa. With Gabriel Carrasco, we conducted a national level study using all the data that we found from race, ethnicity, from NIH, from the National Institute of Statistics. And we thought, we have enough here. We don't have to go door to door to ask people about their experiences when that data is up here. So we requested to change that specific component. And instead of studying the city of Arequipa and race, to go and study migration, health, and land tenure and inequalities in Pedregal. So I don't know what would have happened if we proposed this from the beginning. But we hope to continue working with this population. Everything that we see in Pedregal is what we see in Arequipa over 200 years. In Arequipa, all this happened maybe over 200 years, but now in Pedregal, it's like just seeing a movie fast forward, and in 30 years, the same, introduction of the kissing bug, introduction of rabies, migration, and very rapid urbanization also.
Very interesting talk, fascinating work. I'm thinking in your study where you found no cases, were there all migrants in your sample, or did you have any kind of native or host community to compare with? I'm kind of thinking, as we see, for example, with HIV infection and other infectious diseases, when we study migration, that we've seen how oftentimes what happens is migrants have low rates of those issues when they migrate first, but as they are exposed for longer periods of time in the destination communities, their risk increases because of interaction, with the environment, social, physical, etc. And I was wondering if you've looked into these somehow, maybe comparing, within the migrant population, over time, whether people who were, settled there for longer periods of time had higher rates than, I know you found 0 cases, but anything in your qualitative work that might suggest that risks accumulate and increase even for these zoonotic diseases as they stay longer in those communities.
So they are moving from an area that is hyper-endemic because of the way they raise their animals, how they live with their dogs and all that, to an area where there is no transmission of these diseases. So we don't think that the risk is accumulating in these areas, specifically for those 3 parasitic diseases. Rabies is a different thing. You just bring a new dog with rabies and then people are exposed. But here you need cattle, but you need many more things to lead to transmission. So we don't think that their risk is increased. We sample people from 3 areas. Puno and Cusco, from Cusco Espinares, which is an area with active transmission of these 3 parasites, and Puno, which is Melgar, which is an area with active transmission of 2 of those parasites, and also people from Arequipa. And Arequipa is not hyperendemic for those diseases. So that was going to be our control group or our comparative group. We found now. Also, something important is that many of these parasites, even if you get cured, in the images, you can find the scars, right? Some of these cysts, even when they die and they calcify, you can see something. The same with the neurocystic sarcosis and even the fasciola, the little worms that live in the liver, they also cause engrossment of the liver ducts. So you can see something there.
We'll take one more question. There's a class here after this. Mariana?
Great work, Ricardo. Very interesting. I wanted to ask you about the questions about the climate change, the perception in the community, because I've been thinking a lot about, looking into the literature and very little about, asking people about the lay individuals about the perceptions about climate change. And I see that you identify the extreme events. I think probably, going on the line of extreme events, I think people are starting to connect those dots. But what about other factors in the interviews or in the surveys, and how did you?
So in this, especially in the focus groups, and it was in the focus group, people describe how these extreme events affect them. For example, they say some rain is good for the crops, but a lot of rain during a short period, completely, you lose all your onions, you lose all these. And of course, that usually is followed by some droughts, which is also bad. So the flooding was the most extreme, but many times it just changes in the pattern of rain that affects the way they raise their crops. I should have mentioned that that data was collected with an instrument that was adapted from the work of Stella Hardinger. She has been working a lot on climate change, and especially understanding how to collect these perceptions from the people, because you don't ask people, what do you think about climate change? That is not in their mind, right? But you have to find the right set of questions. And yeah, she has been working on that, and we used an adapted instrument from her work.
Thank you. Thank you to everyone online. As a reminder, our next CCUH event will be on February 12th at 2 p.m. Philadelphia time. We'll have a webinar by Dr. Aina Roca-Barceló from Doctors Without Borders. We'll talk about her prior work on malaria effects on temperature on mortality in Sao Paulo. So thank you everyone, and gracias again to Ricardo.
Thank you.